Now the next speaker, probably I don't have to introduce very much, Bernhard Wörmann, the oncologist, a German hemato-oncologist working practical at Charité, the German University Clinic, and being the medical director of the German Society of Hemato-Oncology, and in Germany, one of the most experienced persons in the AMNOG, so German HTA procedure, giving us his perspective. Thanks.
Thank you very much for inviting me again. This is really hard to beat. I think if we go to the GBA next year, this will be different. I guess I'll start where you finished, because I, of course, agree that HTA and approval have to be working together, but I certainly would insist as a clinician that you also have to have the perspective of the guidelines. And I'm quite convinced that if the whole procedure in the future will be successful, people have to have confidence in the whole procedure. It doesn't help much if it's approved and if HTA assessment is good, but the guidelines say don't do it for whatever reason, either because they already know that within 2 months there will be a better drug, like now in bladder cancer, for example, or in others which are already on the scope and we know about it. So I think it's quite important to put it together, and especially for patients, it's very important to put it all together. That's why I'm again active to promote the clinical perspective in that. Robin has already done the political work, access to new drugs, so I just add the clinical perspective as one of the goals from the medical societies, and allow myself to just over-impress you. This is the current guideline for multiple myeloma, and only for relapsed refractory multiple myeloma. And if you are still asking if you need specialists to explain it, no, I think I can always finish my talk now. But why is it so important? We have just now many drugs that have been analyzed and developed in parallel. They have been approved in parallel, and on a clinical perspective, it's not as messy as it seems to be if you just look at different actions. For example, if you really look at clinical perspective of patients that are refractory to a specific drug like lenalidomide, if they have been pre-treated like with the proteasome inhibitors, no anti-BCMA treatment previously, or if they're also refractory to another drug, then that decides what we recommend. But if in that specific situation a new drug on this very left side should only now be compared to that drug which is used and recommended in the guideline for that specific group of patients, and you don't have to compare it to 15 other options that you have in this condition. So if you really look at the clinical perspective involving those experts, I think it makes it much easier. You can just follow on that. If you have a patient who had an anti-CD3 treatment but no proteasome inhibitor, well, yeah, you should give a proteasome inhibitor and not look at a CAR T-cell probably at that stage. Or if you look at a patient who had no anti-CD38 antibody, you should use it now because it may save years and you don't have to give a more active and, of course, more toxic treatment, and this goes for the whole procedure. So I won't go into detail, but this is just to underline how for us now it's difficult to integrate everything, and I don't think that for non-specialists it's much easier than for us. So how do we see our goal? If we just make it's kind of a different schema that you've seen many times ago. So where's the position of the national societies? Of course, I think we should have a comment on the JCA and explicitly show if it is in line with what we recommend in guidelines. It's a little easier for us now. I think in many countries, including Germany, we have kind of a structure to do that. And number 4 is quite important. The magnitude of clinical benefit scale, which has been developed by ESMO for solid tumors, now is also available for hematology. And Barbara Kiesewetter has published this last year. So in addition to the evaluation that's done by HTA, we have an own clinical benefit scale, which I think adds substantial weight to a comment by the medical societies. What's my vision? I think once this procedure starts with the joint clinical assessment, I think I did it now for hematology, because I think definitely EHA is at the forefront also in Europe. We need something like a central coordination. We need it for cardiology, we need it for rheumatology, now we need it for hematology and also for oncology. I think if there's a central coordination, we can base a comment on the current guidelines. Then it's quite important. We, of course, have to make sure that this is in line with the current guidelines of the respective societies. That's a problem for societies because many of them are not really up to date. So that's a challenge, but it's a positive challenge. And the most important thing will be we have then to go to submit that proposal from the European Expert Working Group to the National Expert Working Group to be sure that this really is something that all 27 countries can agree to, and that's the whole discussion that we're having about PICOs. And then hopefully if we come back with that, we come up with a consensus document. Looks very messy, very complicated. I don't think it really is, because I really think that national societies can benefit from that. We have learned that many national HTA boards are not in contact with sufficient numbers of really qualified experts. In probably half of the European countries, we find that there is already cooperation, that at least in the other half, there is hardly any cooperation. So if the medical society prepare documents, I think the national process can benefit from it. So there is a connection between that. This is, of course, all about the PICO scheme. I won't go into that. We have already heard about it and discussed it. But I think, what's our vision? I think we can end up with something like one sheet, which is then presented to, as a comment to JCA. I think if we have an expert group, they will not have too much pain to agree on 1 or 2 comparators. And then if they then submit it to the countries from 1 through 27, they just make their tick marks. This is our standard. Probably, like in number 9, there will be a third comparator in one country. Well, we have to discuss it if this is representative for whole of Europe. But I think in most cases, a group of experts on the European level will agree on a proposal, and then the national expert can just make their mark, and that is feasible work which can be done. Same for primary outcome. I think there will be agreement on most efforts, and probably with few exceptions. And then I'm very much to what François just presented, and we'll be there with 3 or 4 PICOs probably, and not with a number of 30 or anything. EHA is at the forefront, so that's something which is very important, and hematology is certainly outstanding there. This, of course, then goes back to the national societies, because if there is a good document which can be used, that's less work than for every national country to do it again, so they can just base it on the EHA or on the EU Medical Society document. Can it use it for their national document? So that's a save of time and of effort. Of course, in the future, we can also use this cooperation then to go into the joint scientific consultation, and we won't have to build up a new network. So probably that looks good for you, looks quite impressive, but where are we? Well, not so many national societies have applied, unfortunately. So if I just look at the medical specialties, then yeah, there are some, and in oncology, some are quite important in that, but also there are many, many missing. I did not list the Biomed Alliance as an umbrella association because that's a national specialist society, and the list of red is longer than the green list. Many of the quite important fields are not there. We hope, like medical oncology, ESMO will now be accepted as a stakeholder. That's quite important for the whole procedure. This is almost the last slide. I still have one message again. I think there also has to be some change of mind in how we talk to experts. The EMA and many others are still used, also in some areas in Germany, parts in Germany, we use single experts because it's easier to talk to them. I hope with the algorithm on multiple myeloma, I've convinced you that the time of single expert is mainly over. You can talk to one person, but really to be sure that this is representative for everybody, I think it's hardly feasible. I think if you have an expert, he has to be very representative, but for the network and not just talking by himself. So it's not only about structures, it's also about networks. And of course, again, for the societies, it's about professionalization. I think that certainly will be an incentive for all societies. They have to become more professional, and EHA certainly is very advanced at that. I'm very thankful for that, but there's a long way to go for many others. Thank you for your attention.